Hi, my name is Dr. Rajat Nan Ahmed, and I am a psychiatrist working in UK. And I'm doing this video especially for the IMG junior doctors who are about to or going to start a job in external emergency department. And I've got Dr. Usama Basit with me, who's actually an ST7 in external emergency trainee, and he's currently doing a fellowship in Peds A&E as well. And Osama has got experience, quite experienced doctor now. He's working on that level. He's originally graduate from Pakistan who came to UK in 2014. So he has got a grasp of the system. So the main reason we are doing this to actually explain the structure of A&E and how things work there. So first of all, I'd like to thank Osama for joining me and giving me your time and doing this for the IMGs.
Oh, not at all, Dr. Adnan. Thank you so much for having me. Really happy to be here.
So, Osamat, there are some basic questions the IMGs will ask because they may not have seen the excellent elementary structure in their own countries, or if it works, it might not work the same way as it work in UK. So first, I like to ask you, can you just explain what is an A&E department like? What is the structure like? How is the setup? What are the different sections?
So I thought about how best to answer this question, and I think the best way would be to take you on the patient journey. So when the patient comes in, he or she they book in and at reception, whether they're brought in by ambulance or whether they walk in through the front door themselves. They book in via reception, and then they are triaged. Now, triage is a concept where a capable person, a qualified person, assesses you initially, just a quick assessment, and just to sort of categorize you into how soon you need to be seen, what sort of urgency your presentation requires, and if you're, for example, let's say you're ticking the boxes for a really urgent intervention or urgent assessment, then you get moved quickly to an area where you get seen and you get flagged up. Or you may be triaged as one of those who could potentially wait a bit to be seen. So you first wait to be triaged. It's usually in most A&Es is done by a qualified nurse who's senior enough and qualified enough to know, based on observations and based on the patient's presentation, which direction this situation is going. If they need to be urgently seen immediately, sometimes they flag it up at triage and a senior doctor can come see them. Sometimes what happens is they can refer you to a particular specialty directly. Like, for example, you may come in having been referred to from your GP to one of the specialties. For example, you're waiting for trauma and orthopedics team to see you. So rather than waiting for 2 or 3 hours in A&E for someone to see you and then realizing that you need to go there, this triage nurse or this triage person can then refer you directly to the specialty, so you don't have to wait. Sometimes patients may not be sure what sort of intervention they require or which center they need to go to. So sometimes they can be referred to an out of hours GP, for example, or even the pharmacist as well, just for advice. So this is a good use of the triage system, where you can then you can categorize patients into different categories. Now, based on those categories, you can either be sent to so there are different areas of A&E. You can be sent to resus, which is basically the area which is usually one-to-one monitored. So you usually get one nurse monitoring a single patient, or depending on the resources, it may be slightly different. It's a constantly monitored area as well. You're sort of hooked up to all sorts of machines and observed continuously. So patients who require urgent interventions, patients who require urgently to be monitored, or require treatment that requires certain monitoring, can urgently be sent to resus. And moving a patient to resus usually means that it will be flagged up to potentially a senior person, a senior clinician in A&E, to see them directly, regardless of what the wait time is and what the queue is. The second place you could be referred to while in A&E is the majors area. So first bit is the resus, which is the critical care bit. then is the majors area. Now, majors is basically it's where you come in and require, for example, a cubicle to be assessed, to be managed. This may or may not result in an admission in hospital, but definitely for the first initial assessment, you require a cubicle, a trolley, a room assigned to you within the A&E majors area. This is usually, for example, patients for majors with potentially might be someone who's fallen over and unable to get up due to painful hip, and you're not sure whether they've broken their hip, so it would not be appropriate without an x-ray for them to be sitting in the waiting area or sitting in a wheelchair. Or patients, for example, who've sort of fallen over, injured their head, and are potentially bleeding, that sort of situation where you don't want them to sort of wander off or potentially drop their GCS and become confused. So they'd ideally be in a majors cubicle. Some of these patients who are brought in via paramedics as well, they're mostly taken around to majors as well, depending on the urgency. Sometimes they get taken down to resus. Another way where the patient might present is sometimes there's what we call a pre-alert. So there's a red phone in A&E where if you're picked up by the if you're a patient who's been picked up by the pre-hospital team of paramedics or doctors or any of the pre-hospital team, they think you are unwell enough to sort of warrant urgent intervention, then they can call up early and warn the A&E staff to sort of create a space for this sort of person arriving. For example, a major trauma has happened, or a car accident victim is coming in, and if they're coming in, they can sort of escalate that, to call in early on the red phone and escalate that to the people in charge, so that they can make sure that the resources are available to deal with that particular situation, and so that patient does not have to wait. So we've talked about resus, we've talked about majors. Where there's majors, there's going to be a minor area as well. It's a bit of a misnomer. The minor area is by no means doesn't actually mean that the patient will be a minor illness. It just means that it may not be as urgent or may not require as extensive management. It doesn't mean that the condition or the presentation is less important. It just you get taken to a separate area, which is usually staffed by clinicians who can be emergency nurse practitioners as well, who are qualified to see these. It's usually patients coming in with isolated injuries, for example, twisted ankles, isolated bone injuries as well. Anything that will potentially cause you to be seen, treated quickly, and then likely sent home. Some of these patients may require further intervention. For example, if you may discover in an isolated injury, in an isolated limb injury, you might discover that there's a certain fracture which requires urgent TNO review. So those patients can be referred to the TNO team for urgent surgery type situation. But usually the minor injury unit, you go in, you are assessed, you are treated, and then you are usually sent home. Burns are burn cases, soft tissue injuries, isolated injuries. There are patients, for example, who walk into A&E and are triaged as minor injuries, and then once in the minor injury unit, if, for example, they also say, oh, yes, I twisted my ankle, but I twisted my ankle by fainting and sort of I lost consciousness and then I hit my head as well. So that is not then a minor injury patient. That patient will then be moved to the majors area. So obviously, whether you're referred to any particular area, an assessment is still going to continuously happen, trying to make sure that you're getting the best possible care. So just because a patient is in a certain area does not mean that they may not have a different complaint. Obviously, mistakes happen and things slip through the cracks. So we've spoken about resus, majors, minors. Usually no A&E is complete without having a pediatric area. It's usually a separate area. There are particular rules for the pediatric area. There needs to be separate entrances, and the area needs to be separate, staffed by separately qualified nurses who are qualified to see and treat pediatric injuries, pediatric ailments, and also who know pediatric life support for your rare but worst case scenarios. Usually the pediatric emergency department is also is in good contact with the general pediatric department, and there's usually some sort of overlap between either staffing or at least coverage by your clinicians. So we've spoken about all of those areas. Every department, every trust may have different other things as well going on. You may have stuff like a burns unit separately for burn injury patients to go to. You may have a sexual health clinic, a genitourinary medicine clinic, where you can be referred to as well. So depending on what the policies of that particular trust are, there could be potentially different areas. There are AMS decks, or quick assessment units that people can be referred to as well. They can be referred to via the GP, or they can walk in and be referred by the triage nurse or by the clinician seeing them. So that was the patient's journey from booking in and then being triaged. After you've been triaged to that particular area, there's a role of the wait time. Basically, if you're lucky, you're seen immediately, regardless of your presentation. But usually, A&Es for the past few years are struggling. They're understaffed and underfunded and overstretched in resources, and so you've got a limited number of staff to see a lot of patients. So they try their best. This is where the triage system comes in. So whoever needs the most urgent treatment gets it first, and that leaves some of the patients then waiting, sometimes hours-long waits to be seen. So basically, if you can wait, if you're deemed to be fit enough to be able to wait, then you join a queue of patients waiting to be seen, and then in time order, a clinician, next available clinician, will see you. They'll call you into a cubicle to be assessed. If you're already in a cubicle, they'll see you in that cubicle. Usually the format is going to be the triage nurse has already made a quick assessment, and also he or she is empowered to sort of request certain investigations, so that by the time you do get to see them, maybe sometimes 2 hours down the line, some of those investigations have been done. For example, if you came in with a twisted ankle and the rules allowed it, he or she would have requested an X-ray of the ankle, so that once the clinician has picked up your card, they'd then have that X-ray to hand as well, just to make otherwise the clinician sees you, then decides that you need an X-ray, then you wait for an X-ray, and then they see you again once the X-ray is done. So just in the interests of saving a bit of time, some of the investigations may be requested earlier. This leaves us with a few problems. One is, yes, it's ideal that you have all the information once the clinician sees you. Sometimes the person requesting the tests does not actually know the extent of what tests might be required. So some important tests may be missed out. or they may not. It's obviously a triage situation, so it's a quick assessment. So they may not have the full information to order a wide breadth of tests. The other bit is they may actually going off of a tick box situation where, oh, you've come in with chest pain, you get all these sorts of tests. So extra tests may be done, where if someone's been punched in the chest and come in with chest pain, that's a different situation. Potentially may not even require investigation, and just a history and an assessment by a clinician would suffice, and some analgesia. However, they once the clinician sees them, they may find that a chest X-ray has been requested, and troponin or D-dimer may have been requested as well, based on their presentation. Now, if those are normal, then that's fine. But if they coincidentally come back as abnormal, then you're in a bit of a pickle, because you now have to solve a problem that wasn't actually there initially. So there's pros and cons for every situation, but by and large, everyone tries to do a good job, and I think the intent is to help and to sort of expedite matters. So ideally, you take a history, you do a physical examination, you form a sort of differential diagnosis in your head based on the triage assessment, based on what the patient presents with. And then you do investigations to sort of rule in or rule out stuff. Sometimes it's barn door, it's very typical. It comes in with chest pain, has some ECG changes. The treatment and the management and the diagnosis is fairly simple. It's a STEMI. But then there are the cases where it's the gray area, where they come in with a bit of chest pain and they've got a bit of a cough as well, but the pain is a bit pleuritic as well, and they had some trauma as well, and they're on warfarin. So then you have to sort of go through all those layers and peel those layers away, and try to come up with a diagnosis. At no point are you alone in an A&E. Whenever you require guidance, at whatever time, you make a plan for yourself, and then you take it up to whoever's the next senior person up the road. You can ask them for advice. You can discuss the case. That's what I do. That's what most clinicians do. However, regardless of how senior or junior you are, you sometimes need to discuss the case with someone, and it may just be for advice. It may be for, I'm stuck, I do not know what to do. Or it may just be, this is my idea. Do you think it's all right? Or do you think you might have a different opinion on how to deal with it? So always ask questions is a good plan. Sometimes it's also good to ask the patient what their expectation is. Sometimes they may know more about their illness than we do with our medical knowledge. Because they've been living with their medical condition for 20 years, for example, rheumatoid arthritis, or they may be undergoing some chemotherapy for a cancer, and they may actually know more about their disease and what is to be expected and what treatments need to be offered. So you might just there's no shame in asking the patient, is there a plan in place for you? Do you know what the plan is for your, if such a thing were to happen? And they may even come up with a plan. They may have a written plan in place for what to do. So there are many avenues for you to seek advice. There are protocols everywhere. There are protocols on the walls of every A&E. If it's a resuscitation scenario, if it's a resus case, there's usually a book of printouts of protocols of all sorts of scenarios present in resus. If a patient is having an epileptic fit, what do you need to do? You just pull out that paper and then you go through the protocol. If for example, a patient presents with SVT, this is what you need to do. Like I said, at no point will you be alone. Whether you're new, whether you're 3 years, you've had 3 years of experience, it doesn't have to be that you're new to the country. You can sometimes rotate every 6 months and turn up in a trust that's completely new, has completely different protocols. So it's always good to ask. it's usually quite overwhelming, and that feeling of overwhelmedness
Mm,
is very normal for everyone.
mm,
So ideally, I think just form your opinion once you've interacted with a patient. Come out of that interaction with an opinion, with a plan in place, and then you can ask for advice about what needs
mm.
to happen. Um, and I think that's about it
Yeah.
from that point of view.
So I think you mentioned the doctors and that you're never alone. I was going to ask you about the hierarchy of doctors because when we see in NHS, these where I work, there very generally speaking, there are junior doctors, then there are middle grade doctors, and the senior doctors. Usually, our IMG starts as a junior level when they're first starting. Most of them start at junior level. So, is it the same structure in A&E that you have the junior doctors, middle grade, and then the senior doctors, and the trainees and non-trainees are working mixed together, working?
It's exactly the same thing. So the structure usually, like you said, is there's a senior tier which is usually made up of consultants, and then there's a middle grade tier where you anywhere from SD4 onwards is part of the middle grade. They can be training grades. They can be non-trainee middle grades. They can be locum doctors. Locums are basically who are ad hoc present in the department. They're non-trainees. Um, and then there's the junior tier, which can be anywhere from the foundation doctors to the SHOs. And when I first came to the UK, I was very confused because there can be many different names.
Mm,
But these are the three tiers: the senior tier, the middle grade, and the junior grade tiers. Um, People use terms sort of interchangeably as well. There's an SHO. It can be a trust grade SHO. Can be there's so many. It's it's okay to ask as well what the person's level is. It's very appropriate to ask if you're not sure. Some A&Es have scrub colors that are different for different tiered
mm,
doctors, and some places have different colored lanyards,
mm,
or the lanyards can actually say what level of doctor or clinician they are. Never assume that a person is a medical doctor. They may be a clinician. There are allied clinicians as well who join the department. There's advanced clinical practitioners who come from a background of either nursing, or they can come from paramedics, and they can be part and parcel of the clinical group of clinicians who assess patients. There are obviously nursing staff tiers as well. So there's a senior nurse present always, more than one sometimes. And then there are different levels of nursing as well, depending on their seniority and their experience. So if you're a junior grade doctor who's come in for their first ever job in the UK, and you're very overwhelmed, my two bits of advice I think would be go directly to the nurse in charge, introduce yourself, tell them you're new, and that just try to listen to them. The nurses will teach you so much because the doctors will come and go. The nurses are always there. They own their patients. They own the department. They are really particular very protocol focused. They know their stuff. Doctors will come and go, but the nurses will stay there. They'll guide you. They'll save your
mm,
skin quite a bit. I know it's hard for me to say this, but um, sometimes we come from countries where there's quite a significant discrepancy between nursing staff and the medical staff, and doctors are considered maybe better than nurses. That is not the case over here. That shouldn't be the case anywhere, but that's definitely not the
mm,
environment that you step into when you come to the UK.
mm,
So try to be friends with the nurses. They really know their stuff. The stuff they're responsible for, they're really proud of, and they will oftentimes save you if you've prescribed the wrong diagnosis, tried to give the wrong medication. They will maybe question you. So allow them to question you. If they're asking you a question, that means that, you need to have a think about this medication, about this treatment, and really, really be on it. And just give it a thought. Don't be offended by someone questioning your management. It's not about you, it's about the patient. So if someone asks you, do you really think this needs to happen? If you really think this needs to happen, you just explain, yes, I do, and this is my reasoning for it. And if you're confident in that reasoning, that should be all right. But if they're not sure, and if you're not sure, then they will take it up with one of your seniors, because at the end of the day, at the bottom line is that the patient care should not suffer, and we're all a team.
And I think that's very good that you explain the hierarchy and what to expect as a junior doctor. But the other thing that confuses, and I think this was confusing for me as well when I first came from Pakistan, and I didn't realize the role of an occupational therapist, for example. So I understand there are different MDT staff or MDT healthcare staff working in A&E, and you mentioned the nurses and doctors. Sometimes could be physician associate. What else can you expect in when you go to A&E? You know, what other types of MDT staff you might see?
So depending on the time, so A&E is a 24-hour service.
Yeah.
Exactly the same people should be there that are in the morning, should be there in the evening, should be there in the night. But obviously, some people are paid to just be there in the mornings, and they don't cover weekends, and they don't cover nights. Some of those staff members that you may see in A&E are pharmacists, which are really helpful, because sometimes you're not quite sure what drugs to give to someone. For example, a pregnant patient turns up and they're vomiting, and that you've already exhausted the first couple of options that you have. So it's a good idea to throw around ideas with the pharmacist. Pharmacists also sort of are helpful when, for example, a patient is unable to tolerate oral medication. They can sometimes be converted, their oral medication can be converted to IVs or even topical patches, which is always helpful. You can always access this resource from BNF, and you can always access it online as well. However, having a real live pharmacist with you is invaluable. You can come across physios as well. So physios particularly are really helpful, not just in the fact that in the injured patients, it can be in patients who are, for example, of the geriatric age group, who are very elderly, and physios form a team which can assess them for how safe they are on their feet. Sometimes a patient may be medically quite well enough to go home, but that does not necessarily mean that they are safe on their feet. And you sending them home might cause them to fall and injure themselves even worse, even though they're otherwise physically well enough to go home. So physios make those assessments, and they're really helpful and invaluable. I find I certainly don't send a patient home who I think is a risk until they're cleared by our physio teams. And that situation can happen if it happens overnight. Sometimes you have to admit such patients so that they can have this assessment in the morning. So aside from physios and pharmacy staff, I've already mentioned the ENPs. So your minor injury units, your fracture clinics usually are manned by our emergency nurse practitioners, who are really capable, qualified nursing staff who've had advanced degrees in advanced nursing education, and are quite qualified to assess these injuries and to manage these injuries. And sometimes they can come to ask you for advice as well. And they're really capable because they've had years of experience of doing these minor injuries, whereas you may not have had occasion to assess any of those minor injuries. Who else? So aside from your usual qualified nursing staff, there's also healthcare assistants, which are really helpful. They do a lot of important jobs that that are really, really valuable for patient care and for you as well. If you need anything, the HCA is the best person to ask. If you need to know where some piece of equipment is, they'll know where they are. What else? There are technicians as well. So technicians and porters are really invaluable. So transferring patients is part and parcel of being in any ward, any clinical setting, but transferring patients from one area to the other, from bed to X-ray to CT scanner, those sorts of things require porters and technicians. There's in some trusts, there's a clinical skills technician, a CST, which is probably the most invaluable person for you, because they are qualified to do blood tests and put in cannulas, and they will also save your bacon so many times, because when you realize that a patient has been waiting 3.5 hours and they've not had a cannula and they've not had bloods, and it's completely on you, and you have no information available to assess this patient aside from talking to them, you'll be so grateful if you go see this patient and the cannula's already been done and the bloods have already been taken, and they also do like ECGs and stuff. So that's a really important role, and because they're so good at it, and they've done it so many times, they sometimes get the most difficult IV lines as well. So they really save your bacon sometimes. I think off the top of my head, radiographers are really important as well. And this is the other bit that I had to get used to. So when you request an X-ray, you need to sort of qualify that X-ray about why I need it and who's requesting it. And these radiographers are empowered to ask you questions about it. If they feel that the request is inappropriate, they can refuse to do they have every right to refuse to do the X-ray. So make sure you're not just doing it to pander a whim. Just make sure that the relevant patient requires that relevant X-ray. Sometimes it's difficult to do a particular X-ray, or you're not sure, and so these radiographers are really invaluable. They can even advise you what view to do, or whether or not this sort of scenario is for an X-ray. They may advise you to go for a different modality of scan. So that's always invaluable.
I think you covered a lot of. The next question was about what to expect as a junior doctor and how to approach your first job. I think you covered a lot of that.
Yeah.
But still, I like to see if an IMG is coming from a country like India, Pakistan, or the other countries, Egypt. What do you think? What sort of things you think they struggle with? Because there are things we all struggle with when we first came in. What sort of things they struggle at in the first job in A&E, and what can they do to improve their understanding of it?
Oh, this is such a vast topic. I think we can have a whole talk on this,
Yeah.
just this topic. What I think the basics are. So I'll go with my experience of what I experienced when I first came in. You'll at every point you'll be overwhelmed, so that's very normal to feel. And just don't be too polite. You can ask questions of each and every person you come across. Usually there's a period, a 2-ish week period of shadowing initially. You must receive an induction orientation. So if you've not received that instruction, you must ask for it, because that is absolutely necessary. It's a right to you. It's also a patient safety issue. You need to know exactly what these protocols are and what the general overview of joining a trust, joining a department is. So some of this is going to be in written form, some of them is going to be death by PowerPoint, but some of it is going to be live lectures, and some of this training you have to do online and attend courses as well. So just make sure when you're starting a job that you know when your orientation induction is, and not to sort of start your clinical work before then, because some of it may not seem necessary, like what sort of fire extinguisher to use for what sort of fire.
Yeah.
But there are things that are absolutely necessary. For example, what blood bottles to use for which blood tests. if you like, I came from Pakistan. I came from a country where the trend usually was that the bloods had been done by the nurses, and the doctors would do the medical bits, the clinical bits. But if you over here have to have occasion to take bloods yourself, you need to know what the protocols are. And so I think a 2-week period of shadowing is usually it's offered by the employer anyway, but make sure you also suggest it if someone hasn't offered it to you. So that period of shadowing is for you. Okay, make sure that you attend every day. Make sure you're attached to someone who's at your level of job, so that you know what is expected of you. So that would be ideal, so that you follow them around, see what they do, how they assess patients, uh, how they talk to their colleagues, how they respond to questions, what is expected of them. You can also talk to them what sort of place that is, where what accommodation is available, if they have any advice for you. So that's your time to sort of gain as much information as possible without the responsibility of actually doing any of the stuff. Some people do 2 or 3 days of that shadowing without doing anything except for just listening and watching and observing quietly. I would say within that observation period, you begin to see your own patients without the responsibility. So that person who you are shadowing will have the responsibility for that patient's management actually. But you see the patient, you make a management plan, they observe you, or you go back and discuss that patient with them. And if they can't help you, you go to the next tier of doctor or clinician to help you make a plan. And don't be embarrassed. You have the knowledge. That is why you've got this job. Okay, you have the experience. Just believe in yourself. Things are different. It's a completely different culture. It's a completely different workspace. Even when you've been in the country for 7 years, and you move from one hospital to the other, it's a feeling of overwhelmedness.
Yeah.
It's a feeling of everything is new. So that feeling doesn't ever go away, and that's a very normal feeling. I keep saying that because no one actually told me that that was normal. I just felt very overwhelmed. So I just want to tell everyone who's starting a new job, it's okay to feel that way,
Mm.
and to talk to people, and they'll tell you, oh yeah, I felt that way as well. So make sure you ask lots of questions. Everything will seem new to you. Don't and people will not know what background you've come from, what level of learning you've had. I've said this before as well. When I came here, everyone kept talking about a bladder scanner. I had no idea what a bladder scanner was. So a bladder scanner is basically an ultrasound machine, a basic ultrasound machine, just to scan your bladder and see how many mils of urine there is in there. And it's everyone just assumed that I knew it, but I'd never seen or heard
Yeah.
of a bladder scanner before. So if you've not seen or heard of anything, just ask that question. Even if it seems like a very obvious thing, even if people are talking about it so normally, like as if you should know it,
Mm.
you still ask them.
Mm.
Usually 9 times out of 10, people are really, really helpful. They will want to talk to you. They will learn. They will want to teach you. Sometimes they can get irritated, but don't take it personally. That might be a them problem. That is not a you problem. Okay. So just focus on your learning, focus selfishly on your learning. They might be very busy. They might be irritated. They might have had a bad day, but just you're there to learn. And just in order to do your job properly, you need to ask those questions. So make sure you ask them. The shadowing I've covered, the question answers I've covered, and then just I think there's no other way to do it except to just get thrown in the deep
Yeah.
end and just finding your way. And there's no set measure of, oh, you must see these many patients in this amount of time. So just initially, you'll be allocated a supervisor as well. So meet with your supervisor, who's going to be a senior clinician in the department. Meet with your supervisor and sort of talk to them and ask them what the expectations are for you, and then keep going back to them
Mm.
every sort of couple of weeks. Just
Mm.
say, oh, I've sort of struggled to see more than 2 or 3 patients here, or I'm seeing 20 patients in a day. Is this normal? So they'll guide you through it as well. So just slow and steady, just build it up, and see how you do.
Thank you for. I think you have given a lot of helpful tips, and but a lot of IMGs will still ask for resources. I think you mentioned that knowing your trust guidelines about certain things is very important. How to manage certain conditions and what are the protocols. It's very important, and very important to understand the computer system, the IT system, how to check bloods, how to make referrals, how to order scans, and all of that investigations. But as there any resources, any books you recommend if somebody is starting in A&E, they should read, which will cover the common emergencies or common presentation that you see in A&E department.
So the first and foremost thing I think is when you're working in A&E, there's the Oxford Handbook of Emergency Medicine, which is a pocket book, which is really, really good. Just if possible, it's not very expensive. I believe it's for 25 or 30 pounds. But get the latest edition because obviously changes come up. I think that's ideal. If you've seen a patient, you just go through that. It's a short, concise summary on what to expect, what investigations, what management, and what sort of subtle nuances. The other bit would be if you're planning on a career in emergency medicine, and even if you're not planning on a career in emergency medicine, if you're working in emergency medicine, the Royal College of Emergency Medicine has really great resources. It's called RChem Learning, so Royal College of Emergency Medicine Learning portal. So you can just Google that. If you make an account with RChem Learning, I think it's a £100 subscription for the whole year. And you gain membership and you get lots of resources that so you get the same curriculum that trainees get. And there's different resources for ultrasound, for critical appraisal, for all sorts of presentations, geriatric, pediatric, gynae, surgical, etc. And at every level. So it doesn't have to be, it can be for consultant level, it can be for senior trainee level, it can be for a junior doctor level. So you can select your level and those are really, really good resources. There can be some exam format resources as well, so they can test your knowledge as well. So those are really good. The ideal bit about the RChem Learning is as well that if you then apply for a training post later on in emergency medicine, you can use that as sort of continuous as CPD points, basically, just to show commitment to specialty. Like, look, I'm so committed to this specialty that I've done all these modules on RChem Learning. So those are really good. So Oxford Handbook of Medicine, of Emergency Medicine, and RChem Learning. The other resource is the people in the department are always going to be there to help you. It's not going to be 2 or 3 people. It's a huge family. It's a huge department. So your supervisor will always be there to help you via email, via physical face-to-face, one-on-one. Usually nowadays, in the past few years, I've also seen trusts do this mentor thing as well. So once you start in a job, you'll be assigned a mentor as well. That will not be your supervisor, but can be any clinician slightly more senior to you who's been in the department for a while and who can guide you as well. So just any questions, clinical, non-clinical, professional, personal, you have any clarifications, you can ask them. They're all there. They've been there. Everyone has to have a starting point. They've all been through this, so they'll understand. So don't worry. Ask any questions.
I think you have given us a lot of good points. I think something I also repeat as well when I'm talking to new IMGs. Important things you've said around asking a lot of questions, and don't be afraid to ask a lot of questions. And when people are very busy, you might feel that you are on a back foot, and you might feel that you might make them angry or irritable by asking questions. But even in that situation, if you're not sure, it's much better to ask question and treat the patient safely than
Yeah,
actually stay back and then do something that
exactly.
can cause harm to a patient. So at the end of the day, we are all there. We're all doing this job. We need to keep reminding ourselves that we are all doing these jobs because of patients, and patient safety and patient care is very, very important. And for that, if we have to ask a lot of questions or work a little slow or find out what to do next, I think we should not we shouldn't stay back. We should actually go ahead and do that. So thank you very much for sharing all the information. I think you have covered everything which I was going to ask you. Is there any other tips? I think one of the things I say to IMGs around A&E this is it is actually a good job. I've seen a lot of my friends who started first in A&E, even when they didn't want to do A&E, they wanted to do medicine or a psychiatry or something else. A&E gives you that broad-based experience, because you see all kind of patients there. It gives you a very good insight into how NHS works, because you are constantly speaking to the other specialties and you're seeing what are the referrals being made to them. So it helps to it is a very good team environment, very well supported usually. Obviously it's a lot of work, most of the I don't know of any when doctors are just uh, don't have anything to do, there's always something to do. Then you but as I said, it gives you a lot of opportunities to actually improve your clinical skills, improve your skills to communicate with other specialties as well. So I think overall A&E is actually a very good start, a very good job, even if people who don't want to do A&E as a trainee, still a very good start for an IMG in NHS. So is there anything else you want to tell us or say? Because you have covered, I think, the questions I was going to ask you.
I just also wanted to add, I think that no one actually realizes before coming here that it's a very high pressured job.
Hmm.
So any job, I think, in the NHS is very high pressured, but there's no sort of sitting down and sort of it's it's full on, it's continuous. As soon as you enter the shop floor, it's called the shop floor, the center of the department. As soon as you enter, it's like jumping into a deep end, and you're sort of attacked left, right, and center. Because it's so under resourced that they're just waiting for the next person to come in to see all those patients. Um, but it's a very rewarding job. It from the really simple things to the really complex things as well. So you can be part of a person's most worst day of their life. You can give them really really bad news, and be there in their really critical moments, or even in their dying moments. And you can just make them feel better by, for example, if they've come in with a dislocated shoulder and you relocate it, and they'll be really really grateful because you've managed to ease their suffering. So I think it's really rewarding. It's not monotonous at all. It's you never know what's going to come through the door, and it's all undifferentiated. Like I said, a chest pain can be anything, a headache can be anything. So it keeps you on your toes. It's constantly keeps you thinking, and constantly keeps you guessing about what's next going to happen. So I think that's really good. But bear in mind, it's very 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 high pressured, very responsible. There's a lot of onus of responsibility on you, because like I said, that chest pain could be anything. It could be anxiety, it could be an MI, and whatever you diagnose, it's all on you. So make sure you're sort of you speak to people around you, and just make sure if you've got any concerns that are overwhelming you, you need to talk to people to clarify. The other bit of resource that I wanted to suggest was, my name's Usama Basit. I'm on Twitter. I'm available on email as well. usamabasit@gmail.com. Absolutely happy to answer any questions at any point in time. If you need any guidance about the NHS, about working in emergency medicine in A&E, or just want to say hello, I'm absolutely happy to guide. This is why we're all here.
Oh, thank you for joining me and giving us this useful insight into the Department of A&E.
Thank you so much for having me, and thank you for doing this. This is